Hello, everyone. Good evening, and welcome to this Facebook Live with American Oncology Institute. I have with me Dr. Shashikant Donnalagadda, who is a senior consultant for ENT, head and neck oncology at the American Oncology Institute. Dr. Shashikant has completed his MBBS from the Karnataka Institute of Medical Sciences, his MS from Bangalore Medical College. He has a fellowship in rhinology from Leahy Clinic, Massachusetts. He has another fellowship in rhinology from Tufts University, Boston, and a fellowship in head and neck surgery from Springfield, Illinois. He's worked as the lead consultant for head and neck oncosurgery and ENT at the American Oncology Institute for the last 8+ years. He's the recipient for the Medal of Honor from the governor of the state of Karnataka for excellence in otolaryngology in the year 2005. Sir, thank you so much for taking your time and speaking to us today. First and foremost, I'd like to thank you as well as all the other medical professionals for their service and hard work during these pandemic times. So,
Thank
friends,
you.
today we will be talking about a very, very serious as well as a contemporary subject. I'm sure all of you have come across this term, black fungus, or technically as it called, uh, mycomucosis, or doctor will correct me if I'm wrong. So, first and foremost, tell us what exactly this is before we get into the deeper understanding of it.
Okay. Good evening, everyone. It's my pleasure to be here. Uh, you're all aware of the latest disease that is afflicting post-COVID patients. It's called black fungus. That's a layman's term. In medical terms, it is called mucormycosis. Mycosis means fungus. Mucor is a species of fungus, which is a type of fungus. So, mucormycosis is the fungal infection caused by mucor species. So, it is not a new disease. So, a lot of people keep asking me, oh, I'm hearing it for the first time. Is it a new disease? I've never heard of it. I think COVID has started this. No, it is not a new infection. It has been there. It's been described way back in 1870s. So it is not something that is come out of the blue suddenly after COVID. The thing is, we are noticing more and more cases after COVID. We don't see cases such with such prevalence normally in general public when we don't have the pandemic. But because of the pandemic, because of the COVID, we are seeing more and more cases, and public are more aware. And because of the media, there is so much importance given to it, and people are thinking it's a new disease. It is not a new disease, but the fact that it is occurring in so many people at once is new. That's what we need to keep in mind.
Sure. Sir, like you just mentioned, and I would just like to underline that. So, it is not the incidence which has increased, it is just the prevalence of it, which maybe is bringing it more into attention. Would that be right to say?
No, the incidence has increased. Incidence and prevalence are more or less the same terms. The incidence has increased because the number of patients who are getting infected with this fungus is increased dramatically.
Right.
It was very less previously. Probably, I would say one in a million used to get infected with this, but now we can see more and more patients. To give an example of this, in the past 8 years, I've operated a couple of patients, and those patients were in ICU. One had bone transplant, one was a severely diabetic whom I had to operate for this invasive fungal mucormycosis. But in the last 5 days, I have been seeing like 8 to 9 patients, and there are a couple of patients I've attended on phone call also. So just
Right.
in 2 days, I've seen like around 8 to 10 patients. So you can imagine the difference in incidence now versus previously before the start of the pandemic, where in 8 years I've seen 2 cases. So the incidence has quite increased because of the COVID and COVID related issues.
Right. So thank you for clarifying that to the viewers who are watching this broadcast this evening. If you have any question, and I'm sure there are many out there who would like to know more about the condition, please put in your questions in the comment section, and Doctor will be very happy to answer these queries for you, sir. Moving along, there is also a lot of fear associated with this condition. So, would it be all right to say that the fear is justified, or should it be like just because people don't know what it is, there is more fear? than it is required?
That's a good question. I think, unfortunately, the fear is justified here.
Right.
Unlike COVID, the mortality rate in COVID, even at its worst case, is like 2%. It's normally less than 1, but even at its worst case, is 2%. The mortality rate of a mucormycosis, if it is limited to the nose, is around 30 to 40%. If it goes to the eye, is around 50%. And if it spreads to the brain, is close to 90%. So you can imagine the difference in the mortality rate between a normal COVID and post-COVID mucormycosis. So it's a 50-fold increase. So it people are justified in getting apprehensive about this fungal infection. So, but again, there is a lot of confusion in the public. Not every fungal infection is an invasive mucormycosis. There are other kind of fungal infections called allergic fungal rhinosinusitis, which are very dormant form of disease where the disease is not because of the allergy, it is because of the body reacting to the allergy
Mhm.
a fungus and producing an allergic response. Patients present with polyp, but those patients are always chronic. They don't present in a matter of couple of days or weeks. They present in overs. They have sinusitis features, nasal blockage, polyps coming out of their nose. But these are all chronic problems. So not every fungal infection or not everything fungal associated with nose or sinuses is mucormycosis. The vast
Sure.
majority of allergic fungal rhinosinusitis, and those are not dangerous. But what we
Sure.
see in current today in India right now, because of the post treatment from COVID with steroids, what we see is invasive mucormycosis, and that is dangerous.
Sure. So one of the concerns that I've heard from people is that given the fact that it is airborne, that it is out there in the air and people can inhale it, people attribute it to be more dangerous than COVID. But I don't think that is exactly a direct correlation one can draw.
Yeah, exactly. You're right. So it doesn't spread from human to human. Like if I cough, you won't get black fungus. The reason for that is you already have black fungus in your nose. There are a lot of
Right.
spores in the fungus. There are a lot of spores in the and molds in our environment, in the attic, in the roof, in the soil, everywhere. So normally a normal person inhales up to 57 lakh spores of fungus every day. So you can imagine how much fungus will be there in there. And not every fungus is dangerous. So
Right.
it is not airborne, not it is transmitted from patient to patient. It is not the presence of fungus in the nose that is problem. It is the presence of fungus in an immunocompromised patient that leads to catastrophic consequences. So that is important. Everybody has fungus in their nose. So if you swab 10 people, 8 might have Vicor, or some might have aspergillosis, or some might have other fungus. So the presence of fungus in a nasal swab does not by itself mean that you have an infection. Infection is defined by definition in invasive mucormycosis is the presence of fungal element within the tissues of the sinuses or nose, inside the tissue, not on the surface of the tissue, inside the tissue. That is the definition of it. And that is a serious problem. Just the presence of fungus is not.
Sure. Sir, now at the beginning of the discussion, we discussed about the fact that post COVID, we are seeing a greater prevalence or greater incidence of the disease. So, can you draw the correlation between COVID and post COVID black fungus and how both these are working together to make matters so dire and difficult?
Exactly. That's the most relevant question as of today. See, COVID itself does not cause black fungus. That's again the question a lot of people keep asking me. Oh, I had a COVID. Is the virus or something related to the virus that is causing me? Uh, no, not directly at least. The vast majority of the people who develop black fungus or mucormycosis post-COVID treatment are the ones who had high-dose steroid therapy. And unfortunately, at this stage of pandemic where everybody is in chaos, where the medical system is haphazard, a lot of patients are even self-medicating with steroids in a dose that is highly inappropriate. I've seen patients get 4 5 times the steroid that is what is actually tolerable or what is accepted limit. The reason being the steroids prevent cytokine form and reduce the mortality in COVID, which is true. Steroids do help in steroids, but extreme high doses and given in prolonged duration causes immunosuppression. Immunosuppression is where the body is not able to react to the fungus in a way it should. Normally, there are neutrophil cells in our blood which kill the fungus the moment fungus steps into our tissue. But because steroid suppresses the neutrophil activity, there is a significant decrease in their ability to kill the fungus. That is why you get the infection. Otherwise, fungus which stays on the surface of the epithelium should remain on the surface of the epithelium. But because your immune depression, not only because of steroids, because of tocilizumab and other remdesivir, whatever we are using, nobody knows exactly why the immune system is going haphazard, and because of the immune deficiency, we probably are seeing increased incidence of COVID. It is not the presence of virus or not the presence of COVID virus in itself, but it is the presence of immunodeficiency that is arising as a result of either the treatment from steroids or some other drug which is causing this problem.
Right. So there are a lot of questions that are coming in from our viewers, and because they are specific, I'll take them a little later. Those of you who have questions, continue to put them in the comment section. We will get to each one of those as we continue this conversation with Dr. Shashikant. Sir, my next question is, you just briefly touched upon the correlation between COVID and mucormycosis. Sir, now, if we understand this right, COVID reduces your immunity, and then as soon as your immunity is down, mucormycosis can affect you. So, would that be a simplified way of putting it across?
Uh, you're right, partially. COVID does reduce your immunity, but not everybody with COVID gets mucormycosis. There are comorbidities that the fungus likes people who have diabetes, especially diabetic ketoacidosis, whose blood control is very bad. The presence of ketone bodies and acidosis is a growth medium for fungus. So a lot of patients who, unfortunately, India is the diabetic capital of the world. So we have a lot of patients who have diabetic who are getting COVID. On top of it, steroids given to a diabetic patient with COVID further enhance the presence of mucormycosis. So COVID directly causing immunodeficiency or inhibiting mucociliary clearance that is leading to decreased elimination of fungus can be a role, but we don't know yet. But what we are presuming, and rightly so, is maybe the steroids mainly, and maybe tocilizumab or other drugs are reducing our immunity. But the purpose of those drugs is to temporarily decrease the cytokine storm to treat COVID. So that is a double-edged sword. On one hand, they are helping you. On other way, they are what we are making us to develop what we call as opportunistic infection. The definition of opportunistic infection, as the name suggests, there will be waiting when there is an opportunity, and that opportunity is given by either the COVID, we don't know, but most likely from the treatment from COVID, these fungus get an opportunity to invade into your body, and that's where you are in trouble.
Right. So we are having a discussion with Dr. Shashikant Jonnalagadda on mucormycosis, or black fungus, as it is popularly known across our society today. Sir, one very important question from an Indian standpoint. So, is this a trend which we are primarily seeing in India, or has this been established elsewhere, but we haven't heard of it yet?
Yeah, that's an interesting question, because I was discussing with my colleagues. It is seen everywhere in the world, but the incidence in India is far, far higher than what people are seeing or were seeing during even their COVID peak in their respective countries. So we definitely, even without the pandemic, mucormycosis has an higher incidence in India. After the pandemic, whatever the numbers we are seeing is far exceeds any other country. I have not heard from my colleagues across UK or US, where when I was discussing with them, seeing so many mucormycosis, either right after the peak when patients have got treatment, or much after the peak, maybe because we are using steroids so rampantly, and most of the steroids in our country are used for COVID in a setting that is outside the guidelines. So that might be one reason why we are having more mucormycosis than probably other Western countries. But again, data is still emerging. We can't comment on that yet. We don't know what is going to happen in future, or will those countries develop 2 months later in endemic, and I won't call a pandemic, an endemic or an outbreak of mucor. We don't know, but this is our basic guess at this point.
Sure. And sir, before we get into more specific questions, in addition to the immune compromised state, as well as diabetes, which you mentioned, are there other risk factors like age profile or genetic profile or gender or so on, who are more prone to this disease, or is it not quite clear at this point?
No, there are no gender specific or age specific. generally elderly tend to get it because they're again immunocompromised more than a healthy average 20-year-old. That's the reason they get it more, but there are no specific age-related risk factors. I don't think so. Any other genetic component plays any role in this, at least at this point, no.
Sure. Sir, getting a little more specific about the disease itself now, one of the key challenges with COVID was trying to understand the science and get to a physician at the right time and so on. So, with mucormycosis, again, there is a lot of information, misinformation, and confusion amongst the people. So, if you can clearly explain our viewers, how do you identify this disease and at what point should you be concerned?
Yeah. So, if you had a COVID and recently you had taken steroids, doesn't necessarily mean you will get mycosis, as I said, but you need to watch about some signs, what I call dangerous signs and symptoms that you need to be aware of. The first thing you need to know is increased nasal congestion and stuffiness, serous sanguinous, that is bloody stain discharge from your nose, discharge of pus from your nose or eyes, swelling of your face and the maxillary areas. These are the areas. Swelling around the eyes and the maxillary areas, presence of blackish elements in the nose, or presence of blackish eschar, what we call on the hard palate, which is right up inside your mouth, the loosening of teeth, and intractable pain, that is pain out of proportion to what you had previously, retroorbital pain, that's pain below the eye, headache, these, and most importantly, double vision, loss of vision. These are the most important signs that you need to watch out. Any of these things at this point, and if you had a COVID treatment, is mucormycosis until proven otherwise. So, any of these symptoms you need to watch out carefully, and you need to visit your ENT as soon as possible to either get a CT scan or an endoscopy, whichever is appropriate at that time, and have an initial diagnosis. So, these are the warning signs that you need to keep in mind.
Sure. Sir, a lot of people are asking about the precautions because understandably, a lot of people would like to keep away from it. So, if you can help our viewers understand, how do you prevent against mucormycosis?
The prevention is basically eliminating the risk factors. If you're diabetic, you need to have a perfect control of your diabetes, talk to your dietitian, endocrinologist, and have your diabetes well regulated, especially when you got steroids post COVID treatment. That is the only controllable factor in your hand that you can do. Regulate your diabetes. So once you do that, there are a couple of other things which I don't know per se would prevent it, but it's worth trying it. It is called Netipart, using a nasal saline irrigation with salt water. It is basically salt of the consistency of your tears. Basically, it's a rinse. It is been practiced in yoga for many years. It's called Gel Neti, but there is a modified version, a commercially available bottle with a salt packet. I can add 200 ml of distilled water. Again, as I quote, distilled water, not any water, distilled water into that, and add one packet of sachet of salt in it, and irrigate your nose from right to left and left to right, at least twice a day. That will help. Maybe in preventing, I am not sure it will fully prevent the occurrence of mucormycosis, but it may help in the prevention of mucormycosis. But you have to make sure that you use a clean water and do it twice a day, and make sure you keep your nose healthy. But again, uh, diabetic control, especially in our country with so many people having diabetes, is the key step that they can take in the prevention of COVID. Other than that, avoiding moldy areas like dust areas like cow dung, or any areas where they're wet and damp may be helpful. But again, none of which are seriously known to prevent this illness. If it were to occur, it is mainly because of your immunodeficiency. So nothing much you can do to prevent it other than controlling your diabetes or immunodeficiency.
Sure. And I said, pardon me if I'm going slightly away from your areas of expertise, but you spoke about immune compromised state. So, are there things which both people with diabetes as well as the general population do to improve their immunity post COVID? Because that seems to be quite an area of concern.
Yeah, you can improve your immunity partially by having a healthy diet. There are, if you consult your, most of the patients who had COVID nowadays get a cocktail of medicines. It is a templated medicine. They get zinc, they get vitamin C, they get multivitamins, and eating a good food probably would help your immunity. And staying indoors and staying away from your sick people. As we know, everybody knows social distancing in COVID. These might help boost immunity, but there is no pill or no drug that will like on off switch that will boost your immunity like in overnight. No. So the only way you can do anything, as I said repeatedly, and I'm telling again, is to control your risk factors, which in our case is diabetes. That is the single most influential factor in your hand, is the control of diabetes. That is what you can take care, and that's what you should focus on.
Sure. So I hope our friends Deepika and Bonnie, who've asked these questions, have their queries answered. Should you have any more queries on similar lines, feel free to put them in the comment section, and we'll get to those questions. Dr. Shashikant will be happy to answer those for you, sir. Moving along, again, I might be asking something which is more of a public health and not specifically ENT, but because you did touch upon subjects like cleanliness and places which are infested with dampness or cow dung and so on. So, how much of personal and social hygiene and sanitation will help improve, prevent some of these conditions?
It will help to a certain degree. As I said, you cannot control the fungus. Fungus is not COVID virus. You have to remember, fungus is everywhere. It is on your bed sheet. It can be on your backboard, or it can be on your clothes. It can be on your damp, moist cloth that you wipe your floor off. It can be everywhere. It is very unlikely that you would avoid inhalation of the fungus. It is practically out of control. You can reduce the number of spores that you inhale, but you cannot eliminate it. If you reduce the fungal burden, maybe your immune system is competent enough to take care of it. That's a hope. Again, so avoiding damp areas, avoiding a visible area of mold. You can see a lot of fungus areas in our bathrooms. If you look at your ceiling, you'll find a black mold of fungus. If you look at your bathroom tiles, that is the only. So avoiding damp area of mold. You can see a lot of fungus areas in our bathrooms. If you look at your ceiling, you'll. Hello.
Yeah, I can listen to you.
Yeah, so you can avoid these things, and that will cleanliness in that aspect would definitely help you. But we don't have a data to how much degree would it make a difference for you to whether contract a mucormycosis or not. See, for COVID, we have a definite data: social distancing, staying 6 feet apart, masking, not being around sick people definitely helps. There is a data proven science. In
Sure.
mucormycosis, it is based on common sense that it would reduce the incidence of infection, but we don't have a strong evidence like we have in COVID. But anyway, you need to take every hygienic precaution you can do with or without mucormycosis. So it makes sense that you keep your surroundings clean for any matter for that.
Sure. So you use the word an endemic or a pandemic. Pandemic is, of course, the coronavirus right now. You did say that mucormycosis could end up being an endemic. What kind of chances are we looking at? Could there be a explosion? Because right now we are seeing, yes, there is a definite increased incidence, but could there be an explosion like we have seen in case of coronavirus for mucormycosis in India?
That's a question you put me on a spot. Your guess is as good as mine. We don't know. I don't know the answer. I hope there is no endemic. I don't want to see so many patients, but nobody can guess what the number. We are seeing a jump in the incidence from what we saw previous pandemic, like 50 or 100 fold. But again, because the numbers prior to pandemic were so low, even we seeing like 3 or 4 patients every day is a huge number for us as an ENT or somebody. Because right, when you see 1 every 4 years, now seeing 1 4 every day is a huge jump in numbers. Definitely. So would it be to an extent where we can call it endemic? I don't know. Would it be a spike that will cause a major public health problem? We don't know. We hope certainly not. But it's very difficult to predict because we are still not out of the coronavirus wave yet. There are a lot of people who are undergoing treatment yet. There are a lot of people on steroid currently. So we don't know how many people will further develop mucormycosis in days to come.
Sure. Sir, I'll come to the treatment aspect of it as we run the clock down on our time that we have. First and foremost, what's the protocol for the basic level of treatment a patient should be getting for mucormycosis?
Okay, the first thing, the key step is patient identification of the symptoms, then visiting doctor. That is the first barrier. The earlier you identify your symptoms, visit the doctor. the better it is for you and for the surgeon too. So the moment you have these nasal symptoms or eye symptoms or whatever symptoms, if you visit an ophthalmologist or an ENT, mainly an ENT, then you have the early diagnosis. The first thing would be to get a CT scan, so see where the fungus has spread. Sometimes an MRI will also help. So we need to see where if the fungus is limited to the sinus cavity and areas behind the sinus cavity called pterygopalatine fossa, there is good news for you, because surgical debridement, removal of the fungal element, clearance of the pterygopalatine fossa, opening up all the sinuses, and then that is most important, starting antifungal therapy, intravenous, which is mainly amphotericin B, could be life saving and also vision saving for you. If you present late, for example, with the involvement of I already have double vision, blurring of vision, there is vision has already deteriorated more than 70-80%, or you're totally lost your vision, then in addition to clearance of these, which we call the debridement or endoscopic sinus surgery, you would also need removal of the eye, which is orbital exenteration. And if it had spreads to the brain, then we'd have to probably open up the cranial cavity also in rare cases. So that is a very bad prognosis. So the treatment functional predominantly would be a nasal sinus surgery, in most cases, debridement of the tissues, then followed by antifungal, which is mainly amphotericin B. There are two types, liposomal amphotericin B and regular amphotericin B. Liposomal amphotericin B has a lesser toxic profile, but unfortunately there is a current short supply of both liposomal amphotericin and amphotericin B in our society. It is very difficult to get, because the drug, which was so rarely used previously, it's being used tons and tons, so the production is just not able to keep up with the demand that we are currently have. Maybe it will be solved in a couple of weeks to come. So surgical treatment, which is debridement followed by antifungal therapy, is the line of management, and most patients would get these. Rarely, if it is very, 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 very mild, you can start with antifungal and see if it resolves, and maybe you can avoid a surgery. That is also possible, but in vast majority of the patients, you are looking at a surgical debridement and antifungal therapy in combination. Either one in its own will not work. When you have a serious disease, it's a combination of both that will work in conjunction with one another.
Sure. So our friends at Oncofax would like to know if there are anything specific to managing cancer patients who might have been COVID affected and then go on to develop black fungus. Would the line of treatment be same, or would there be a deviation from normal?
No, the line of treatment is exactly same. It is again same, debridement followed by antifungals, which is mainly amphotericin B, or posaconazole, which is a new antifungal element. So the line of treatment does not change from whatever reason you get mucormycosis. No, it's the same treatment.
Sure. So you did mention the jump in the number of cases that we are seeing. I mean, from what it was an extremely rare case to now becoming almost a daily kind of a scenario. So firstly, I would like to ask you about the public health infrastructure and readiness that we have in the country to be able to tackle this if there is such a explosion across the country. Do we have the infrastructure and readiness to do that?
Yeah, as I was discussing earlier with my colleagues, I'm not worried about the number of cases. It's never going to be like coronavirus. You don't have millions of people being affected by mucormycosis, and never will be in the future. There is no question in that. It will never be to a number which appears scary. But the problem is not the numbers. The problem is the number of people who can deal with mucormycosis might be the problem, because if you have a COVID, a general physician can treat you, a pulmonologist can treat you, any properly trained, even MBBS doctor can treat you, at least vast majority of the patients. So 99% of coronavirus patients don't even need treatment. Even those who need treatment can be managed by a lot of people. And the supply of doctors in those specialties is much higher than who can treat from mucormycosis. Unfortunately, mucormycosis is mainly treated by ENT and in association with ophthalmologists and neurosurgeons. The pool of doctors able to manage the mucormycosis is extremely limited. So even a slight bump up in the incidence of mucormycosis is going to cause a public health problem, because the number of people who actually can deal with this problem is quite limited. That is the worrisome factor for me. It is not the absolute number, but the number of people who can actually treat and operate on these patients is worrying me.
Sure. And specifically talking about American Oncology Institute and Citizens hospitals here in Hyderabad. Should patients be able to walk in and get treatment for black fungus at your institutes?
Absolutely, they can come in at any point, even the ER, even if there's sudden loss of vision, they can come into ER. Since we are a non-COVID hospital, we are a cancer hospital. We are not currently operating on COVID positive patients. We need to have a negative COVID report, but that is the case in most of the mucormycosis patients. Most of the mucormycosis patients are the patients who had COVID 1 month back, who had finished their treatment, and then because of the immunodeficiency, they would have developed mucormycosis. So most of them would be COVID negative. A COVID negative report is required by our hospital protocol. But lucky thing for the patient, at least whatever we can say is that most patients are COVID free by the time they contract mucormycosis. There are some people who develop mucormycosis during their treatment. Those unfortunate patients are very few. Luckily, most patients after they recover from the COVID develop it. So at least that's a good thing because they don't have to deal with the two diseases at once. So any patient in American oncology with a COVID negative, we definitely manage it both surgically and with antifungal therapy.
Sure. So, although we are out of time, I'll still take a little more to get a few more questions in here. First and foremost, sir, although we have extensively spoken about how mucormycosis affects those who've had coronavirus and then been remitted of it, but that I understand does not mean that those who've not had coronavirus can take things very easy.
No, see, your chance of getting a COVID, like you and me, even if you're diabetic, even if let's say both of you are diabetic, is extremely rare. Okay, it is not that every diabetic will get COVID. So your chance of having COVID is so chance of having mucormycosis is so rare that you can't fundamentally do anything to prevent it other than taking care of your diabetes. Even if you have diabetes, you're more likely to develop other complications related to diabetes than develop a mucormycosis. The patients at risk are immunodeficients like bone marrow transplant patients, the oncology patients. Again, even in those subset of patients, it is extremely rare to develop mucormycosis. That is what is baffling us, all the doctors, is what kind of immunodeficiency is caused by COVID that is causing so higher incidence. There is some difference in the immunodeficiency caused by treatment of COVID or COVID itself that is
Right.
different from the immunodeficiency arising from other things. So the incidence is much higher in COVID. Again, we don't know the reason. We have to
Yeah,
wait
of
for
course.
the.
I would understand, and there could be a lot of people for other factors, like even, for example, people who might be on immunosuppressants for other reasons, or organ transplants, or people who've had a immune system deficiency, or rather excessive, in cases of rheumatoid arthritis and all, they might be on drugs which suppress their immunity. So it's not like immune suppression is something which is rare and is only happening after coronavirus.
No, immune suppression is common. It's either due to innate disease or due to therapy or due to diabetes. It's quite common than due to immune suppression due to corona. Again, as I said, we don't know a lot of things in COVID, and we certainly don't know a lot of things in black fungus. So it is difficult for us to tell. Again, maybe the acute use of steroids and sudden immunosuppression in a patient who was previously immunocompetent may be one of the reason. Again, I'm speculating. There is a lot of data analysis that will go on after this pandemic. We might get answers to those after we get the data. Without data, it's very difficult to answer at this point. We can't speculate anything. The only thing that is in our control right now is to how best to treat it and save as many lives and as many vision as possible. That's all we can do at this point.
Sure. And sir, there are a vast majority of people writing about this particular condition on social media, on the internet, and talking about it on TV channels and so on. And it suddenly looks like it's a very, very dire situation. So, from whatever you have spoken, yes, I understand it's concerning, but then I don't see it to be as dire as it is being made out to be. Would that be a fair thing for me to take away from this conversation?
See, it may not be a dire public health crisis like COVID is. No, it definitely won't be to such a degree as I already told you. In terms of public health crisis, it may not be as big public health crisis, or it certainly will be nowhere near the public health crisis that COVID has posed us. That is not the problem. But for a patient who contact mucormycosis, it is a much bigger problem for him to contact mucormycosis than to contact COVID. So for him, it is a catastrophic consequence. For as a public or a society in itself, for a public health measure, it won't pose a threat as the COVID has done. Or COVID is a massive thing. It's a pandemic, claimed millions of lives worldwide. So this won't be catastrophic. But as a layperson, to put it in a random way, how would I put it? If I were given a choice of getting either COVID or black fungus, I would choose COVID only, because I am more likely to survive COVID than I would survive a black fungus if I were to get one. So, for a personal standpoint of view, black fungus is bad.
Right. Sir, this has been a hugely informative talk. I'm seeing messages and comments in the comment section. A lot of people saying the same thing. So thank you so much for throwing so much light on a subject which is so misunderstood, and right now there's a lot of confusion about. So as we part, would there be anything that you would like to tell, whether it is COVID patients or the general population in the country, just to comfort them and assure them that mucormycosis is not going to be as widely prevalent as coronavirus is, and they
Definitely, nowhere near it is going to be as prevalent as coronavirus. You don't have to worry about that. The only thing, as I said, a lot of people will recover from coronavirus. A lot of people will get steroid from coronavirus. You need to watch out for early signs. If you are one of those unfortunate people who develop these signs, visit your doctor early, and you can take care of early mucormycosis also without significant harm. But once it progresses late, then you are in trouble. Again, if you're speaking from a public health perspective, I can definitely assure you it is nowhere going to be nearly as bad as COVID. So public need not take a scare about it. I mean, you need to worry once you get it, or then you need to worry about it. But as a public health measure, it won't be such a big problem.
Sure. Right, sir. Thank you so much to you for answering all the queries that I and the viewers have had. I thank the members of the audience who joined us, who asked the questions that they had. If you need any more clarity, if you would like to consult Dr. Shashikant, he's available at the American Oncology Institute at Hyderabad. Feel free to look up on the details on our Facebook page as well as on our website. You can take an appointment, consult him, not just for mucormycosis, but for other ENT and head and neck oncological treatments as well. Sir, thank you once again for joining us. I couldn't be more thankful to the medical community in this hour of crisis for all that they are doing. To the members of the audience, from Dr. Shashikant and myself, the only appeal is please take care of yourselves, stay home, wear a mask, and wash your hands, and make sure that you only go out if it is absolutely essential and necessary. We'll see you soon again on another episode of Facebook Live with American Oncology Institute. Until then, from myself and from Dr. Shashikant, everybody here at American Oncology Institute, it's thank you and goodbye.
Thank you. Thank you very much. Good night.